Welcome and thank you for joining us in the session Communicable Diseases like TB, HIV and Hepatitis C. Have we won the war yet? Moderated by Dr. Kuldeep Singh Sachdeva, Deputy Director General at the Central TB Division.
Okay, thank you. Thank you, audience. Thank you for joining us. I'm replacing Dr. Sachdeva for temporarily as he gets to nearest point. He's on his way, and I think with some of the cities in India being so busy, Delhi and all, he'll be at his place. But let me introduce the delegates. I think it's very important to hear about the speakers. I, being having done my postgraduate in MSc at London School of Hygiene and Tropical Medicine, love this subject because it's a subject core to me. It's one of those subjects that has raised a lot of attention. That when the process to eradicate smallpox began, it started at the same time with malaria and TB. There were like three sisters that we were trying to get rid of. And we succeeded in one with the smallpox, but we have failed with both TB and malaria. Now, with the recent cooperation we saw globally to deal with the coronavirus, what brings to mind is that, is this bacillus, is the TB bacillus so clever that we can't, as human beings, address it? Or is it there's something lack of a coordination, lack of interest, or has TB become like one of those orphan diseases, as they say, that nobody wants to pay, or neglected, I think is a word for it, neglected diseases. To share with their views this afternoon, we'll have Dr. Kuldeep Sachdeva, who is the Deputy Director at the Central TB Division in India. He'll be moderating this. And then next speaker we will have is Arindam Moitra. He's the faculty of the Patient Academy for Innovation and Research, and where Arindam has really been helping us a lot during this period, preparing up to this session and summit. Then Dr. Vandita Gupta. She's the lead IDV at Global Public Health and Metabolics, Johnson & Johnson. Johnson & Johnson India comes with a huge pedigree of having been engaged in Indian public health for a long time. I mean, it's whether there were bandages, there were this, there was that, baby products. I mean, on consumer side, we all know that for well. And as patients, I think I really like this sterility products they had. Vandita is a physician by education, then undertook a MBA. And she has really got a huge 17-year experience of leadership and strategy in commercial roles. And as now leading global public health efforts in infectious disease and vaccine and metabolics at Johnson & Johnson, she is really positioned to tell us what's going on with this. And as you know, Betaclin against TB last 40 years was the first novel drug. She will address this. Now, Manoj Pardesi, who is the General Secretary and National Coalition of People Living with HIV in India, will be bringing something of a huge experience of 24 years work on this. He's worked with the government, non-government organization, and bilateral and funding agencies, and then looked at the legal challenges to protect rights of patients, meet community needs. He also has a deep interest in international and national development at the community level, and he has helped understand the epidemic from a range of perspectives. He's worked in various aspects of HIV, and as recently with the Population Council and National Institute of Health in the United States, he brings that experience. Now, I would particularly ask Arindam to start the show rolling, and then we'll follow through. Arindam, could you start off?
Yeah. Let me start out with the basic question which has been asked in this session, which is whether we have won the war yet as far as TB, HIV, and hepatitis C. Uh, I will restrict my talk only to TB, although I have an experience of working in both TB, HIV, and a little bit on Hep C. So my association with the TB goes back to 2002, and now in 2020, when I see the long journey that we have made in TB, it's really amazing because it started with a TB program which was focused primarily on the public health aspects of it, and the private sector was something which was different and which was looked at as maybe more as an adversary, not adhering to the standards, not following the standard treatment protocols, and something which needs to be managed, and because they were not following the government procedures, and also the international standards of treatment and all. From there, there has been a sea change in the way we have seen how the TB control in India and has changed.
Yeah.
We have reached a point where it is basically an effort towards TB elimination. So right from changing name to changing a logo, and of course, in entire thought process and the way it has gone about. I can start out by saying, see, one of the landmark here has been 2012. If I take from that point onwards, 2012 was the point of time when first TB was taken on as a notifiable disease. So you had to notify it, and then actually started the point whereby you thought of actually involving the private sector, still keeping it at a distance, and looking to see how you can actually manage it and control it. So that was the attitude at that point of time. And another major change at that point of time, we launched the Niche, a web-based, case-based platform for dealing with TB on a real-time basis, and it has evolved into a system where you can also directly transfer benefits to each TB patients, apart from having the individual data of each and every TB patient in the country who are accessing services from the government sector as well as majorly from the private sector also. And from there on, there were major changes. Like when there was I remember Dr. Sachdeva had gone to a program in TB where there was a controversy between, intermittent regimen and a daily regimen. So now we converted from there to a daily regimen, which was a step which the private sector welcomed because that was what was being usually practiced. So there was no two separate standards out there. From then onwards, it was more of trying to engage into a partnership rather than manage the private sector, and private sector also joined in into its effort. There was a national guideline for partnership which was developed at that point of time, and another major landmark was developing the standards for TB care in India. And the beauty of it was an Indian standards which we had defined and which went beyond the international standards of TB care, in the sense that for the first time this document talks of the social standards for TB care, which was not present even in the international standards. Now, from there onwards, from a situation where, talking of nutrition was a taboo as far as TB control efforts were there, we have come to a premise in 2020 where we are actually providing 500 rupees per month through something called the Nikshay Poshan Yojana. So whereby each TB patient who is registered in the Nikshay portal gets 500 rupees per month during the treatment duration. So that is a big change which has happened. Now, from the micro point of thing to a macro, if you look at it, what majorly has changed has been the political commitment which has come in. Uh, so any public health program changes and there is a definite shift towards the better only when there is a political commitment to back it up. And that political commitment has been shown by the policymakers. And the biggest indicator of it has been a huge increase in allotment, which has allocation in the budget allocation, which has made for TB control. So which shows that.
Thank you, Arindam. Thank you. I'll come back to you, and now I'll go
Sure.
over to Dr. Vandita. Do you follow on from this? Let's see what your opinion is on this.
First of all, thank you for having me on this panel, Kavaldeep. I mean, it's fantastic to share a stage with all these experts who would talk about a very pertinent issue today. And I think, Arindam, with your comments, your comparison on where we began to where we are today, you really set the stage well to come closer home. And there's a new dimension or a different dimension I'm going to speak about when we talk about our war against TB. And that dimension is more going to be on the current context of what this pandemic has done today to TB. And you know, over the past few years, there's no doubt that be it the India National TB program or that of other high burden countries, they've taken bold strides in confronting TB. But there's also now little doubt that this pandemic has caused substantial setbacks. You know, lockdowns on societies have curtailed diagnosis, they've curtailed notifications. Basically, they've curtailed patients' ability to safely access care like they used to, right? And we've all experienced it, we've read about it. I'm sure we've all read the global Stop TB report. It talks about scary numbers. It talks about a 3-month lockdown for a country like India would set it back by 5 to 8 years in its efforts on TB. And each additional month taken to return to normal on TB services would mean about 40,000 more deaths between now to 25. But what I mean to say here on the panel today, that all these numbers, these scary numbers that we've been hearing about, don't necessarily need to translate into reality. There have to be, and there have been, in fact, in the last few months, we've seen these sticks that have been poked into this wheel to stop the circling we need to, and the ducks that we need to have in a row to tackle these issues. I wish Dr. Sachdeva had joined us by now, but
yes, thank you much.
Yes,
thank you, Vandita. Hi, Dr. Sachdeva. I'll hand over to you now. Just to fill you in, I've introduced yourself, your credentials, great one. I've introduced Arindam, and I've introduced Vandita. All your role now is to introduce Manoj and then take it from there. Thank you.
Thank you, Kavaldeep, and my apologies to all the panelists. The earlier meeting actually was unduly prolonged. I missed one VC in between, which was between 2 and 3:30. So do apologize, please. So Vandita, carry on. I suppose, Arindam, we have done the introduction.
That's right.
Now, okay, so you were speaking on how the TB services will be affected by this pandemic, and how do we win the war against TB? That's
yes, sir.
Yeah. Okay, that's
yes,
good.
Dr. Sachdeva, and you just came in at the perfect time when I just called out your name, and I was saying that who better than you would be able to talk about the efforts that NTEP has brought in to combat the effects of this pandemic on TB. A combined strategy of restorative efforts and supplementary measures. Examples, TB and COVID testing in different shifts. Directing all diagnostic centers to provide uninterrupted services. High priority to diagnosis, especially in vulnerable communities. For example, all the efforts towards migrant laborers a few months ago. Ensuring that all TB patients have about 1 to 2 months of anti-TB drugs to ensure treatment adherence. So all these multi-pronged efforts to restore the pace of TB care during these times have been critical. Now, to me, what is further needed to step up is more efforts. And more efforts on raising community level awareness to ensure active case finding, treatment adherence is brought back to its focus in the as it was in the pre-pandemic times. A more widely penetrated adoption of teleconsultation services, we've seen fantastic examples of that happening in the last few years to help more and more patients get on treatment. Faster deployment of innovative diagnostic tools and treatments. We also saw new innovations coming in there. I think these would be a few factors that would notably help us expedite in our war against, especially in these times.
Very well said, Vandita. I'll just pick your thread on community engagement. Go to Manoj Pardesi to share his experiences on the HIV platform. Also talk about a little bit about Hep C and HIV, and then we take on from there. Manoj, are you there?
Yes, doctor. I'm here, doctor.
I hope you have been introduced.
Yes, doctor. Yes, I have been introduced. Thank you so much.
Yeah.
Yeah. And
please, Manoj, let's hear your views.
Yeah. So, sir, are we going to that question answer, or I should just share the directly? You are muted, sir. Sir, you are muted. We are not able to hear you.
Okay. So I'm saying you just share your experiences on what has been your experience of community engagement at HIV program. How do we replicate that for TB and Hep C, and where are the points of convergence there?
Okay. So, thank you once again. Thank you for this opportunity. So first of all, so globally, PLHIV and KP community engagement has proven and able to halt and reverse the HIV epidemic. But since last few years, like said, the way the HIV, the focus of HIV is going down, and we are talking about domestic investment more, that is actually losing the momentum on community engagement. Secondly, COVID has affected all the overall health. So that is also again reduced the HIV testing, reduce the access to treatment, and I'm sure it is also reduced like TB testing also. So everything is contributing towards the at least a break towards our goals of 2030 end AIDS and 2025 for India it is 2025 TB elimination. What is my one recommendations to all key donors? I understand for government service delivery and medicine is the first priority. So that is why I'm requesting to all donors, like they must restart again investing in the community if they want to achieve UHC and SDG. Because COVID has given us like any disease will impact and fuel other disease. So this is the lessons from COVID. Now, coming to your second question, like based on our experience, how TB can ensure community engagement. So one of the, as per experience in HIV response, the biggest shift is from medicalized approach to community and people-centric approach. HIV has bring into the community the right-based approach, where community itself is demanding for the quality of service, which service they want, how they want, those kind of things came into the HIV program. And that I see as a big shift from medicalized to from not top to bottom, but equal approach. That resulted into the removing some punitive laws. HIV is actually brought key population also at one platform, where we have started talking about law reforms. This is I'm not aware about in any other diseases where the community is talking about law reform of removing punitive law, setting up HIV/AIDS Act, those kind of experiences and learnings we had in HIV. I'm living with virus since last 27 years. And one thing I can proudly say that I have not missed my medicine even single day. So the message which I want to give is that previously when Vandita Gupta is talking about adherence, and that is the important factor in any prevention and managing the whether it is bacteria or whether it is vaccine, HIV, Hep C or TB. Second aspect is the prevention, positive prevention. In last 27 years, I can proudly say that I have never transmitted this virus to anyone. So I limited this virus within myself. So our both purpose is getting solved. So spreading of infection is getting stopped, and adherence and quality of treatment outcome is also we are ensuring because of positive living and then positive prevention. TB is much mature program. We all it's much beyond than HIV. Sorry and honestly, I would like to say that since we are engaged with HIV program and we also engage in Global Fund program, so we always come in discussion with TB. At least in last decade, I'm hearing that TB program is struggling to get active engagement of community. And I don't know why, but that is something we need to see how we can ensure that. Something which, just as a recommendation, like HIV is a lifelong condition, that is actually increasing our vulnerability towards TB. So for TB, having a risk of TB is lifelong for me. And in TB, the 6 months course or 9 months course, there is not any much motivation or there is not any much organically that patient should stay in TB program and stay engaged. The community should stay engaged in the TB program. So that is not there organically. And that is why I feel that community engagement TB program is still struggling. So that's where the role of PLHIV or even KP will come in. Like we have already so many people, those who are treatment activists, health activists, irrespective of whether it is HIV, Hep C or tuberculosis. But these people are already having that perspective, that angle. Why don't these people directly start talking about TB? So here you have already army with you. Let's how best we can utilize this army for this 100% cure disease which can be 100% curable. That's the one message I want to give. Thank you so much.
Dr. Sachdeva, you're not audible.
I'll remember that to unmute every time before. So you talked very important points. One is shift from a medical approach to a more patient-centric approach. You also talked about donors reinvesting the money and a right-based approach. So on that, in fact, TB is learning much of its lessons from HIV only. In fact, we are trying to see what can be replicated, if not replicated, adapted and adopted, and then contextualized in the TB context, local context, and then taken up. On this, I'll turn now to Arindam Moitra. He raised important issues. We also developed the legal framework for tuberculosis. We also have a now rights-based approach for TB, though they are in a primordial or primitive stage now, but we have all started thinking on those lines. So, and we also heard Manoj where he says that since the treatment is of a short durations, people are not invested. Patients are not invested in TB program. So what are the challenges you see from a patient perspective, and how do you think we can make them invested in the TB program? For us, the community is both TB patient and also the general community. How do we get both on the board? Your views.
See, as far as challenges at this moment, when we have set such ambitious goals 5 years before the 2030 deadline, which has been set by the world, we have to look at from not from a medical perspective, but more from a social perspective. I can list you a few challenges which I see the program needs to look into. Now, if you start out with the very basic challenge which still persists is stigma related to TB. Now, initially it was thought that it was only related to maybe women, to rural areas, but as you go on interacting with the patient, you find out that stigma is still present out there, and it is so inherent. It is inherent within the, even within the public health system, and there's an inherent fear in the TB, among the TB patients and also the community, that maybe TB is something to be avoided, and if I disclose that I'm a TB patient, maybe it may also lead to loss of my job. My other co-colleagues may not accept me as such. So that stigma, when we started out, that has maybe reduced to a large extent. But if you have to reach the last mile, stigma has to be addressed, and addressed in a more comprehensive manner. Now, Mr. Amitabh Bachchan, the brand ambassador of TB, is as an excellent effort which has been made by TB Control Program. But maybe we also need some female ambassador, because we are missing out on half of the world. So maybe whom do the female TB patients identify with? Now you are talking of TB champions, but TB champions talks of what their individual problems or situations have been. From there on, going into more into a higher level, we have to talk of things which has maybe left out. Like, when we talk of catastrophic expenditure due to TB, now the draft NSP which is out there, in the way we will see that we have targeted that we will have zero catastrophic expenditure by 2025. But as it is very apparent that we don't have a nationwide study to find out what is the actual catastrophic expenditure which is occurring. In some local studies related to few regions are there, which say which ranges from maybe 5% to some say it is 25 to 30%. So that kind of expenditure which the system maybe does not calculate into while planning the intervention has to be looked into, because that is something which matters to a patient. If I'm a TB patient and if I have to give up my day's job in order to access the services, then that's a big loss to me. And if I have to reach the government health facility, that is also an expenditure to me. If I have to window shop at the private sector and then maybe reach the public health facility because I do not have the economic strength to the private sector, that is also a big loss to me, because ultimately I may become an MDR TB patient, and in which case my chances of survival goes down drastically. So a focused ACSM approach, a campaign mode still needs to be carried out, focus on this aspect. Another basic aspect as far as TB patient is concerned is overall aspect of poverty and malnutrition. If you take the cases of poverty and map it out, and also malnutrition, you will find that TB, malnutrition, and poverty is coterminous. Now, if that is the case, then how are you dealing with the issue of malnutrition? Of course, I remember in 2012, malnutrition was something which was a taboo subject, to where we now have the Nikshay Poshan Yojana. But does Nikshay Poshan Yojana reach every TB patient? Has it that kind of reach? And secondly, what has been its effect on TB control efforts as such? Or does it needs to be enhanced? A systematic study and evaluation of this has to be done in order to find out how big a role malnutrition has to play in the aspect of TB control. Now, I can also talk of the preventive TB therapy. We don't have a everybody is talking of the COVID vaccine and when it will come, but in spite of more people dying of TB, we don't have a TB vaccine yet. So maybe it's still a neglected disease if we look at it in that way. But then we have latent TB infection, and recently the program has taken steps to do it. But then how do we scale it up so that scale it up at a level where if people are found out and the latent TB infection is dealt with? Then I will go on to something which my co-panelists pointed out, is also access to new drugs. We have TB drugs. There has been new TB drugs which has come in now. Bedaquiline is there. But then last I read about, we have roughly around 1.15 lakh MDR TB patients. So how many of these TB patients have access to new high quality drugs which are less toxic and of a shorter duration? And how are we going to ensure that each TB patient, irrespective of the fact whether he is in the public sector or the private sector, has access to these new drugs? and also drugs where we don't need injections, maybe WHO recommendation, or maybe going into an oral regimen is something which we need to look at. So these are the aspects which has to be dealt. And apart from that, if I can add on, there's a mental health aspect related to TB. Now, mental health is not considered as a comorbid condition of TB, I know, but if you see, when you take these drugs, there may be some side effects. There are stresses, there are anxiety attacks, and then psychosis is also created in patients. So, but there is nobody out there for him or her to deal with this. So it's high time, when we are talking of eliminating TB, we have to deal with these issues which are very individual in nature and not community at nature. So from a community based approach, we have to be patient centric. So find out what are the issues, real issues of the patient. So when we are addressing this in a holistic manner, especially when we have set such ambitious targets of the TB incidence has to be reduced by to 44 per lakh from 142, from prevalence of 6 to reduced to 65 per lakh, and zero catastrophic expenditure and TB mortality being reduced to 3 per lakh. So those are very highly ambitious targets, and until and unless we provide the TB patients a platform to come and be engaged in a matter where they actually help in policy creation and address their real needs, which has been spelled out, till then it will be very difficult. I know we have reached a situation where it was thought that we couldn't eliminate, but if we could deal it for polio, we can do it for TB too.
Great. Thank you, Arindam. You raised a range of points. For some point, I'll come to Manoj, but at a later time, regarding stigma, TB ambassadors, and catastrophic expenditure. But there are a few points you raised for Vandita. Access to new drugs. She's done a lot of work on beta-glucan access, and also they are also contributing. Helping national program to scale up MDR TB program and putting patients on treatment. So, Vandita, I'll come back a few words on access to new drugs, how the programs can make that happen in a more better way, and how can we collectively ramp up our efforts to eliminate TB. Your views.
Yeah. So, Dr. Sachdeva, thank you for that question. And Arindam rightly covered a range of points. And Manoj, before that, he drew similes between the HIV program and the TB program. We all fully realize that each of these programs come in with their own set of ecosystems, own set of challenges. But I want to bring in a very different example here. And it's a beautiful example of what's possible when the world comes together to combat a public health challenge. And I want to take Ebola as an example in West Africa. I think several of us realize that the global community, it mobilized efforts on multiple fronts to mount an effective response, including developing and deploying new scientific innovations, public health programs, engaging the community. And I think it's a similar kind of mass collaborative effort that also needs to be done for ARDP. What it means is that all sectors, public, private, not-for-profit, and very, very importantly, as highlighted, the communities themselves, they need to come together to solve it. We need to focus on reaching more patients, fully leveraging the existing tools that we have, diagnosing them, connecting them with care as early as possible. But at the same time, we also need to develop even better tools for tomorrow's patients. Point of care diagnostics, not just new drugs, but point of care diagnostics, drugs which would lead to shorter, more effective regimens, and eventually, as Arindam mentioned, hopefully a more potent preventive vaccine. And I also want to touch on a huge silver lining, which I personally believe came in with this current pandemic. I think I've personally loved to see how adoption of digital health in a country like ours has ensured continuum of care, even if it did take an initial 2 or 3 months for that to happen. And we're actually every day witnessing an increase in virtual consultation, digital dispensaries, and so on and so forth. And all of this offers a huge potential for access to, for the patients to care. Arindam mentioned about new drugs not being available. And we knew that could potentially be a challenge when every time a patient cannot be put on patients because the footfall in the OPDs come down during the COVID times in the TB OPDs. But can virtual consultations really bring us back to track? And for our part, I think J&J, we've got a good history of innovating to develop new tools and technologies, and Bedaculin is no different. We've invested significant resources to deliver this treatment to patients, and in more than 100 countries, including all high-burden 30 countries, donating about more than 100,000 treatment courses to low to middle-income countries, running the 4-year donation program that has been much spoken of in partnership with USAID. And as you mentioned, we also feel humbled that we do get an opportunity to work with national tuberculosis programs like that in India as well to support, access to care. Having drug is one thing, but ensuring that the patients are getting it, our healthcare professionals are capacitated enough to deliver those drugs to the patients with their improved knowledge, with improved diagnostic capacities. The second thing, feel proud to have engaged with NCDs on. One effort in that direction, which I would want to quickly talk about, is our effort with FIND in collaboration, of course, with NCDs, is to build capacity and establish new TB culture and drug susceptibility testing facilities at about 7 locations across India. And also undertaking unique collaboration with Union under, again, the blessings of NCDs to support these efforts in that capacity building of public sector. So at the end of it, I think I would like to summarize that much beyond the pill, it is the efforts that go behind the making the pill available to the patient with the collaboration of different stakeholders, different sectors coming together is what is going to help patients.
Point well taken. I mean, we've also seen when a new technology arrives in a country, it's adaptation, adoption within the country's national program. There's always a time gap of few years before they are actually rolled out, and we need to fasten this process. I saw a chat in a comment from Kavaldeep.
Dr. Sachdeva, I've just got 2 comments from the public chat, which is screened from you. Please do read them and address them. Thank you.
I've read those comments. One is a very valid comment. Subconsciously, we still talk of TB control when our program is TB elimination. So many times there's a slip of word, and it's a very valid comment. Let's get into that elimination mode. Though on ground, we are in an elimination mode, but many a times when we do public discourse, we still carry that old memories with us. We will still, people call it RNTCP instead of NTEP. So let's memorize that well. Point well taken, Kavaldeep. So that was the one point I saw from the public chat. Other is, yes, of course, we need good awareness expedition for better management. Minister of Health launched what is called TB Harega, Desh Jitega campaign. So that's a huge campaign which will be rolled out, has been rolled out, and which will be carried on for next few years. So we will build on that slogan, TB Harega, Desh Jitega, and take it from there. So Vandita, very valid points, very well said. Again, coming back to Manoj, how can we address stigma, Manoj?
And Manoj, you have just 1 minute to do that. Thank you. He's running out. Sorry to put you in pressure.
No. There is no any rocket science. It's very simple. Like patient-centric approach and empowerment of patient. So I'm using, normally we don't use patient word in HIV, but here I'm specifically using because in TB it is. So the empowerment, community empowerment has given us to stand against stigma, whether it is society stigma, whether it is healthcare stigma, and that needs to be something which we can think for same in TB.
Okay, point well taken. In the interest of time, I think almost all panelists made great points. We will, as a national program, I say we will take all those points into consideration and move on from there.
So
Having
can I say
said that-
something, sir?
Yeah.
Just one line.
Please.
Yeah. Mainly
Yeah.
on when Vandita talk about the like bedaquiline, it's the latest treatment on TB. So here I just want to give the example of HIV, where community always demanded and advocated for newer treatments in the program, and that has forced program to adapt and bring the new treatment in the HIV, whether it is tenofovir, whether it is rifavirin, and now the dolutegravir. So now it's in the program and it's largely rolled out. Also for testing, we demanded for viral load testing, and viral load is also become the part of the program. Sorry. So these things also we can.
Sure.
Yeah, if community engagement is there, the newer treatment and everything also come as a part. Even what I know about vaccination of TB vaccine.
Thank you. Thank you very much, there's everybody, and we're now moving on to the next session. So thank you for your thank you, Dr. Sachdeva, and
thank you, Kavaldeep, and all the panelists, Vandita, Manoj, and
meet
Arindam.
again in London, in London
sir.
or in
Sure.
India physically. Thank you much, and
Thank you so much.
stay safe, everybody.